started for the afternoon. Welcome back from lunch and dessert-ish. Dessert-ish. There's cookies out. Okay. The next talk is obviously going to be by Magda, Torre, who is Assistant Professor of Dental Hygiene. Her background is not only dental hygiene, but public health as well, which makes her uniquely qualified to talk about health promotion and prevention activities in patients, not just elderly patients, and not just in oral health as well. But you're going to hear about oral health today. And behavior modification is one of those things that is extremely difficult to affect in anybody, no matter what the age, and in the elderly it's particularly difficult, but not impossible.
First, let's test the mic. Can you hear me in the back? Yes? Okay.
Thank you.
Well, good afternoon. And guess what? This is halfway through the week. It's exactly halfway. And I think that we've all been very enlightened by subjects that we knew a little bit of maybe, and now we've expanded and know more about. I think that we've learned about some subjects that maybe we knew nothing about and had minimal knowledge, and now at least know resources where we can get answers, where we can obtain more information. And then some of us might have had refreshers on some topics that we were very familiar with, and it just improved and modified what we already knew and just enhanced that we're doing the right thing. Okay? And I think throughout the week we're going to see that. I've been very fortunate to be involved with the Institute, the Summer Institutes in Aging, several years, and I think that at the end of the week everybody leaves with that feeling of, wow, we're not going to be experts in all of these topics, but we're going to actually have felt that we've gained a lot of information. And again, I'm very happy to see all of you here. As Dr. Saunders mentioned, my topic is a bit divided. I'm going to talk in particular about oral health, and then I'm going to focus a little bit more about health promotion and disease prevention. And if time being, I'm going to share a third portion, which is more on the personal aspect. Okay, to start with, I'm not going to give you a whole lot of information on this. You've heard it from other speakers already. Our growth rate, we know that our population is getting older. We know that we're living longer. We've heard from speakers today and in previous days that what is happening? Science, technology, behaviors, lifestyles, everything is being modified. Think about all of our advertisements that go on. Who can give me some commercials or anything that's out there that talks to us about being young? Viagra. Okay. Okay. What else? Celebrex. What else? How about like cereal commercials or Special K? They want us all to look like this K, right? What else is there?
Botox.
Botox. Cosmetic surgery, cosmetic dentistry. Definitely. We're all supposed to have perfect straight white teeth, no wrinkles, no expressions. What else? What else are we bombarded with every day? How about our cars? Don't our cars even look slick and young, and it's made us to think that a new car is better? Give me some other examples. Hair products. Yeah. So these are the messages that we get every day, right? And so what happens when natural process starts to occur to all of us? And most of us here are women. I would say that, unfortunately, most of us probably try to use some of these products, or at least try them out, right? Because those are the messages that we're getting. Okay. Just another graph. Talk a little bit about how in 2000, look at the numbers of over 65 in the year 2050. Very large numbers. And this will include us probably, and our children. So we've known that the importance of health for all, both young and old, across the lifespan has long been emphasized as a significant societal goal. Okay? So now health promotion efforts should not only address strategies as to how to decrease health conditions, but most importantly, how to improve functional ability and the words that we hear a lot about, quality of life. You know, as we heard earlier today on the lecture on the biology of aging, do we want to live 105? And if we do, what will our quality of life be? So quality of life is something that I want us to keep on the back of our mind as we talk today. So this is the circle that talks to us about what is considered wellness. What are the 7 components of wellness? And it states that if you've got a balance of all of these components, we are a pretty much balanced, happy individual that has a pretty good quality of life. So things here to consider are vocational. Are we happy with our job? Are we happy with what we do? You know, as a teacher, I know I tell my students many times, you know, yes, you've got to make a living, but make sure you have a passion for where you're working and what you want to do. Okay? Emotional. We've got to have emotional balances. We've talked about, we've heard other lectures talk about emotional states, and not to say that some of us are more emotional than others, but there's got to be a balance there. Environmental, you know, we've got to be safe. We've got to have some type of home. And everybody remember Maslow's hierarchy of needs? What's at the bottom of that? Shelter, food, and our environment has got to be a good environment, healthy, safe environment. Intellectual. Who can tell me an example of an intellectual balance? Someone who's intellectually balanced.
Anybody, well, most of anybody about any topic surely shouldn't be a problem for you. You should know a little bit about other cultures and people and jobs and.
Okay. So a well-rounded individual, different levels. I heard the word culture. What else? So does someone with a first grade education and someone with 2 PhDs, would they both be equal? Some of us might say no, some of us might say yes. I think that what this is telling us is that every individual is an individual, and every situation is different. And as long as that individual is functioning, as that person is functioning well in their society, whether it's with the 2 PhDs or whether it's with a first grade education, they can be balanced and they can be well. Okay? Physical, we've heard about that, getting up and moving around. Social, we must have people around us. You know, we hear a lot in the elderly and the frail where isolation is a problem. They lose their family, they start to lose friends because they either pass or move away. Even when you move somebody into an assisted living facility, you sometimes run into, now they've got to make new friends, and it's more challenging the older somebody gets to adjust to new situations, new surroundings. But it's important that we have society around us, that we have people around us. And I truly believe that there's the family that we were born into, and then there's the family that we create. And what I call the family we create is that family that we create through our friends, our peers, etc. So it's important that we become part of a group. Spirituality, I think, is important to have that wellness and a balance as well. We're going to have a lecture on that later on this week. Okay? Any questions this far? Okay. I'm going to talk a little bit specifically about something that's called state of decay. Oral Health America is a national organization devoted to the oral health, devoted to oral health in our country. And they came up with a report, which you all have a copy of. It's called A Report of Decay, the Oral Health of Older Americans. Now this supports numerous findings that oral health for the elderly are in a crisis. Okay? Dental hygienists cannot answer this question, but and it's probably in your notes and you've seen it, but what was that national result? What grade did we get as a nation? Yeah, we got D. That's very embarrassing. And just to think that that is the grade that we have as a nation of what we're providing for oral health care for our elderly. Now, this is all due in part to, these are the things that were measured. Lack of access to care, medical reimbursement or Medicare reimbursement issues, shortage of providers, the people to treat our elderly, disabilities, homebound. Many of our elderly are homebound and cannot receive the care, and many of them are medically compromised. So what was the grade for the state of Texas? Hygienists, don't answer. No, anybody can answer. What do you think? How do you think Texas did? We got an F. Texas received a grade of an F. Very, very poor. That's how bad we're doing. Okay, I have provided a copy of the full report, and in the very back it has all of the states and how every state did. But if you just think that the national average was a D, we're doing really poor. Okay. So in the year 2000, we had the first ever Surgeon General's Conference in our country. And we were very fortunate, and Michelle just stepped out because I was about to surprise her with the next slide. I don't think she's seen it. But there were several of us who were fortunate enough to attend this conference in DC and represent our university. And part of what the Surgeon General reported was that there are definitely unacceptable levels of oral health disease in the most vulnerable populations. And it included children, and it included the elderly. Okay? So the picture I was going to share was from the Surgeon General's Conference, and you can see I'm the third one down, and then the sixth one down is Michelle. I'm not sure if you've ever even seen this picture.
I haven't.
We actually were with the Chief Dental Officer at the time, Bill Moss, but these were the representatives from the Health Science Center. Okay, so let's talk a little bit more. We've heard about medical geriatric assessments, so let's talk a little bit about dental geriatric assessments. You know, what type of goals are we looking for? What is it that we want? Well, we want to emphasize an oral hygiene plan, because what hygienists are the preventive professionals in a dental office. You know, and many times you think you need to go to the dentist because something's got to get fixed, right? Well, the dentist is technically the person who's going to help you fix something. But the hygienist, as the preventive professional, is going to help you prevent something from breaking or prevent a tooth from getting decay. You know, help you with home care, help you with your cleanings, all of these things. So we want to have a plan of how are we going to be able to treat our patient. We want to eliminate pain and discomfort. Anytime you have pain in your mouth, you know, think about a tiny little sore that we might get. A chip, you eat a chip and it scratches you. You know, your gum. You bite into a hot piece of pizza and it burns the roof of your mouth, and how uncomfortable that feels. Now think about our elderly who might have major sores in their mouth, major periodontal disease, very advanced. The pain is definitely there. And just like we heard yesterday, you know, if you've got pain somewhere, you're not going to be able to function. Therefore, the quality of your life is diminished, okay, or at least affected. There was a study that was done, and I think it was a great idea. There was a school, I say it was in Minnesota, and they actually were trying to take away medical or dental coverage from children. And so there was a lot of advocacy going on about, no, you can't do this, children are in pain, et cetera, et cetera. And so what they did is they got a lot of the politicians and anyone who was influential to sit in a school bus, and then they were given and they were only plastic, the little tabs that we use to take x-rays. Now sometimes those are uncomfortable when you have the x-rays taken. Well, they put one of those in their mouth and had them chew on it, and then they drove them around in the school bus, okay, so that they could actually feel what it's like to drive around in a school bus if you've got some type of pain in your mouth. And of course, this was pain that they totally got rid of when they took this little plastic device out of their mouth. And some of them didn't even make it back to the school. They took it off before because they felt it was that uncomfortable. So, but it really got the message across, we need to alleviate pain. We need to do something about pain. We also want to maximize dentition. We know that digestion starts in the oral cavity. So we need to maintain our teeth for as long as possible and maintain the health of our mouth so that we can have good nutrition, good digestion. Things to consider if we don't have our dentition is the whole chewing capacity. Can you chew? What can you chew? It limits what you can eat. Weight loss. Already the elderly are becoming frail. This might exacerbate more weight loss. It may increase the geriatric wasting syndrome that occurs, as well as the decreased ability to swallow. So what would be in this oral health plan? What type of questions would we want to know? We want to find out, is the patient receiving any type of regular oral care? Does this oral care, what does it consist of? What is it that they're getting care for? Who provides the oral hygiene care? Okay. So what is the person's dexterity level? We saw some slides in previous lectures about with someone with rheumatoid arthritis or osteoarthritis. Can they hold a toothbrush? What is their dexterity? We also now, of course, think about what are the mental capacities. What's the patient's ability to self-care? Again, think about all the assessments that we've learned about. Would an adaptive device enhance the patient's independence and ease the caregiver? This is an example of someone that you would see someone's hands and you would definitely need to do something about helping them determine how they can, if they can, help themselves to brush their own mouth. So it goes along as well as if we can take care of an oral health plan and if we can come up with a plan of what it is we're going to do, then we're going to help other problems. We're going to help hopefully reduce the aspiration risk, oral infections and mouth pain, which I already talked to you about. We learned about serostomia, will help reduce some of that, improve poor-fitting dentures and partials, rampant decay, as well as dementia and decreased ability to withstand dental treatment. That is something that we always need to consider. And the videotape we saw today is a good example of that. So again, this is someone with serostomia. And what about their quality of life? With someone with a condition of their tongue is in this condition. What kind of limitations do you think you have if someone had? If you put yourself in this condition, this is your tongue, what limitations would you have? Or would you? Difficulty swallowing? Nutrition? Social. Yeah. Somebody's going to look at your tongue and it's going to look pretty red. Probably it's going to get stuck to your mouth because it's so dry. So talking may not be something you want to do a whole lot with other people. Halitosis. Odor from the mouth because of the dryness of the mouth, no natural lubrication. I heard something else. Decay. And that P, four-letter word I just talked about. Pain. Probably some pain associated with this as well. Okay? So what are the benefits and what are the cost savings of us having an oral health plan? Okay? Well, we are going to improve the quality of life, because we're actually going to try to focus and look at all of these things. There'll be a reduction in dental emergencies where we'll be able to prevent, we'll be able to foresee some emergencies or some conditions before they become emergencies. There'll also be a decrease in the morbidity and the reduced amount of secondary illnesses linked to dental problems. We know that oral health is linked to general health, and that was one of the major messages that the Surgeon General's conference and report gave us. Because oral health is linked to periodontal disease. What else? Low birth weight, low children's birth weight, blood pressure, heart disease. Right. So there's a lot of correlations. If someone's got periodontal disease, there's ramifications as to the correlations that it has with medical conditions as well. And then, of course, we would have improved nutrition and hydration. So as a whole, we've got a dental team that needs to look at the functional limitations, that then needs to work with the caregiver team and come out with the cognitive limitations as well. And it's a puzzle that you've got to put together. It's not one person can't solve it, one provider, one profession can't solve it. It takes an interdisciplinary team. It takes the family if they're living at home. It takes a caregiver if they've got a caregiver at home. It takes a nursing facility. It takes everybody coming together to come up with a plan. And this is not exclusive to oral health services. This is, in general, a geriatric person, an elderly person needs a conglomerate of team, in their team so that you can provide good health. So one of the things also is to consider is, can the patient tolerate transportation to the dental office? Something to consider. Okay, just I had to, after seeing the pictures yesterday, I had to include my own pathology pictures because I thought, if she grossed you out yesterday, I need to do a little bit of that. No, I'm just kidding. But just the extent of some of these conditions, and I feel that for the frail elderly, oral health care is often a matter of medical necessity to overall health. And too often dentistry has been fragmented. It has not been, hasn't been part of mainstream health care. It's been isolated.
What are you looking at there?
I don't know if I've got a pointer. You've got the top teeth. Can you distinguish for the top teeth? And then right underneath that are the bottom front teeth. Okay? And then from there down, all of that is calculus, which is tartar.
Those are the top bottom teeth.
Yes.
So she's-
The bottom teeth
basically
don't have
the
pointer.
left
The bottom, like if I can reach. Sure I can. But you can see the top teeth and then just a little bit of the bottom teeth. And then from there down, all of that is tartar. It's a lot. Thank you.
You wonder how
Okay,
people can
top
get that
tooth,
far.
top tooth, bottom tooth, it ends right here. Bottom tooth ends right here. From here down, all of this is tartar, which is referred to as calculus. And you asked
I
them,
wonder how do they let themselves get that far?
do you think, was it this person let themselves get this far? Not necessarily they did by themselves. This person this person obviously did not have the skills, maybe, the information, the ability,
Depression.
all of these things. There could have been a lot of factors. But somewhere down the line, you'd hope that there'd be a caregiver or somebody who could do this, brush their teeth. Because if just brushing, even if it's just brushing without toothpaste, even if it's just removing that plaque, would have prevented the formation of this calculus. Yes?
Many people think that's normal. They think that's normal, they don't know any better.
Yeah, it's like the commercial they have on TV, the new one where the young woman says, well, I have fuzzy teeth, and I'm like, she doesn't look like she'd be the person to forget to brush her teeth. It's just, they think it's normal.
I have seen this a lot in nursing homes, and I'm sure that you have too. Because who brushes the patient's teeth in nursing homes? Nursing homes?
And that's the last thing they do.
Right, if they have time.
And it's because they're I'm going to get on my soapbox here, but they have so many tasks assigned to them. And does anyone know what they earn?
Minimum wage.
Very low, right? And now to have them do this too? So I don't blame them individually or personally. I think it's somewhere our system needs to be able to fix this somehow. But unfortunately, sometimes it's not a priority. It goes back to what's more important. Let's feed this person, let's bathe them, let's give them their medicines. And this is not given a priority. Okay. So I'm going to switch gears a little. Oh, then I thought I'd show you a calming picture next.
That one took the gold star and the little weed, I think.
Okay,
That
okay,
one.
good. We're going to switch gears a little bit, and here we've talked about oral health plans, what we need to be doing, what we need to include in them. So let's talk a little bit about how are we going to then motivate a person to do them, okay? And we can all relate to this. What I'm going to be talking about is not just about the elderly, but about how do we get motivated to do some of these things? Or how does our mind think? How do we sometimes, has anybody ever told themselves, I'm going to set myself up to do this? Or I'm going to just, we try to fool ourselves to do something. So we're going to talk a little bit about that. To start with, our future direction, of course, baby boomers are coming. We're here. And in 2011, the majority will reach 65. Okay, so we're going to be around for a good while. And again, the added years are supposed to be quality years, so keep that in mind. We want to maintain independence, we want to have good health, we want to have an engagement in life as long as possible. There was a study that I read that talked about where we all stay at an age. Can you all think of what age you think we are all at, mentally and emotionally? Anybody? Not 10. Between 25 to 35. Okay? So I sometimes think that I'm still 25. My body then reminds me I'm not. But think about elderly people that you might know who think they're between 25 and 35. They love to dance, they love to chit-chat, they love to play bingo, they have friends, they engage in conversation. It's possibly their body, their ailments maybe that are older. Can you think of people like that? Mm-hmm. Because the personality is not changing. Okay. So, current myths about aging that we want to dispel. Getting older does not mean that there's this inevitable decline and deterioration. It doesn't mean that. Okay. Also, people of any age can improve their health, and we talked about that, we learned about that today, if they adopt a healthier lifestyle. So at any time. I really like this sign up there. Can you see the elderly people cross sign? That they have those, they actually have those in England, all over. They've got those in England. I thought they were very appropriate. And because aging issues are actually a public health issue. And the value of prevention is very recognized and realized. Also, prevention is the most effective way to stem that escalating healthcare cost that we hear about. We hear how much it costs to care for our elderly. Well, the healthier somebody is, the less that we will be spending on healthcare costs. But there's also social cultural barriers, okay, to this. Cultural barriers are ways that we believe or values or systems that we grew up with that were inherent. And if they contradict the typical medical model or the medical system that we use for our screenings and for our health promotion efforts, then they're not going to be effective. If I go into a community that does not believe in something, how are they going to adapt to it or adopt it? Right? I did some work in New Mexico with Native American Indians, and I worked with this one doctor who would tell us when he first started working there, he actually would tell people, take this medicine, because the Native American culture doesn't have the same concept about time, and most of at this reservation we were at that time, not stereotyping. And so what he would tell them is, take this medicine with your meals. So he's thinking they're going to have breakfast, lunch, and dinner. Well, that wasn't what was being done there culturally. They would have breakfast, and then they would have a very late lunch, maybe 4-ish, and then they would have a very late dinner. But some, these were larger meals, but they were spread out differently. So the times were all off. And people were coming back, and their blood pressure wasn't controlled, and their diabetes wasn't controlled, and all. But it's because he had not taken that step to find out, okay, so he was assuming that they ate their meals at, let's say, 8, 12, and 6, for instance, instead of looking into what's happening in the culture. Okay. So in order for them to take their medication appropriately, you need to look into what is the culture doing. You need to make sure that the person is dependent on not just their culture, but on other factors, their family, their religion, certain limitations that will prevent somebody from doing certain things. Other social cultural barriers in health promotion efforts are that there is a social and political power. And anytime you have a vulnerable group, you're going to have a diminishing of power. And so diminishing of power is linked to poor health outcomes. Okay? as well as racism. It's particularly apparent in the lack of cultural sensitivity to groups who participate in non-traditional healing practices. If someone comes in and they tell you that they are participating in a non-traditional healing process, there is a lot of judgment and stereotyping that goes on with that from healthcare providers. Okay? The elderly and minority women are amongst the most vulnerable in the aged population. So a few more social economic barriers. Does this not make you think how are we going to get our elderly to do some of these things? There are a lot of barriers we need to consider. Another one is just the whole pattern of aging, and the quality of life in the elderly is closely related to economics and the social health of the society as a whole. Okay? Elderly women enter old age poorer than elderly men. And that's usually due to the fact that the majority of women over 65 are widowed and have been in the workforce inadvertently because they've been moms and they haven't worked all the time. So now their pension or Social Security benefits are lower. Some social economic barriers, we talked about some social cultural, now some additional social economic barriers, are that the use of prevention, it's strongly influenced again by poverty. Whether you have prevention measures are influenced by your poverty. It's concerns for food, shelter, clothing. These are characteristics in the elderly which take priority. Health promotion and disease prevention did not take precedence over survival needs. So we're going to talk a little bit about some theoretical models. And these are models that are going to help reduce the risks and promote health. First thing is illnesses are increasingly recognized as lifestyle diseases. We are seeing this more and more. There are also problems of social nature, such as drug use and violence, are also considered chronic now. So we've got some models at an individual level, and these are things that I can do as an individual. And in order to predict and reduce these efforts, it's important that I take it as a personal matter, that it's my own obligation to take care of myself and my health. Okay? Not always something that you will find with the elderly. You'll have people that are very independent, but you will also have people that are very dependent. Who here has not heard of the health belief model? Everyone has. Okay, good. So, okay. Health belief model. The health belief model is, and I know all the students in here have, because I know I covered it in my class, but it basically says it's divided into 4 core dimensions. You have to perceive that you're susceptible to something. Let's say a disease. Let's talk about diabetes. You have to perceive you're susceptible to that. You have to really believe that it's severe. You know, is diabetes bad? Maybe. You have to think, yes, it is bad. You have to perceive there's some benefits to taking your medicine, to watching what you eat. Okay? And you have to believe and perceive that there are some barriers that you either cannot overcome or that you can overcome. So these 4 perceptions and how you handle them determine whether you're successful in adapting a new behavior, whether it be following a diet, whether it be following a medication regimen, any of those. Okay? These can be applied to smoking, to regular physical activities, the idea of just taking medications for hypertension. And I just thought the whole idea of quitting smoking, the health belief model is used for that. And this is just a great example of how people who are smokers feel that they're in jail. Right? Anybody who's been a smoker and has quit? And I heard Roy Rogers said that quitting smoking was really easy. He said, I did it 1,000 times. Okay. So in order for us to be able to apply some of these theories, we've got to have some self-efficacy, which means I need to actually have the confidence that I believe I can perform this particular behavior. Whether it be I'm going to quit smoking, whether it be I'm going to take my medicine, whatever it is, you've got to perceive the confidence in that. So what are the implications of that? That you're going to have to do things step by step, that you're going to plan, that you're going to measure your successes, you're going to seek specific measurements for your successes. And so you're going to incorporate these beliefs about the individual and hopefully have expectations and outcomes. This is what I want as my result. So it's really important that we perceive the perception of self-control over health matter affects our behaviors. So if we think that we can control something and make a difference, we will affect the behavior. We will modify, change the behavior, adapt it, whatever it is that we've set our goal to be, whatever we want our outcome. But we've got to perceive that we have some control. Okay? When someone's told you, you have to do this, was it easier or was it harder when you told yourself, I am going to do this? See, when you tell yourself, because you're telling yourself, I am going to do this. You've got that control of your actions. Okay. The trans-theoretical model of health behavior changes is just very similar, but it gives us different stages. One just tells you pre-contemplation. I'm not going to do anything, and I don't intend to change. I'm not going to take my diabetic medicine. Contemplation is, well, maybe I'll change and take my medication, but I'm not going to do anything about it yet. So preparation, you're like, okay, today is June 8th. I'll start taking my medicine July 1st. So you start preparing. Action is July 1st gets here and you start taking your medication. Maintenance is that you're going to sustain this over time, and now it's September 1st, you go back to your doctor and you've still been taking your medication. Okay? So that's how this model works. And it goes through stages, just like I told you. There's stages of change, there's a process, and there's a decisional balance. You actually have to decide, do I go to the next stage or do I stay at pre-contemplation for 2 years thinking about, I'll think about it, but I'm not going to do anything. Which is kind of where I'm at with exercise now. Theory of recent approach. This is an individual is more motivated to perform a behavior if we feel that the outcome is highly valued. Okay? If I know that if I do something, my peers are going to really value this, or my family is going to be really happy with me if I do this. You know, if I quit smoking, my family's going to be thrilled. If I do, if I know that there's going to be an outcome, whether it be an outcome towards me or an outcome for those around me, that's going to be valued, I'm more motivated to do it. So the factors that affect this behavior: can I do it? Do I have the ability to do it? How much effort is it going to take? How hard is it going to be? How easy is it going to be? How difficult is the task? You know, if I tell myself, I am going to learn to parachute in 3 months, and my brother is going to be so thrilled because he was a trooper and he parachuted. Well, that's a pretty difficult skill to do in 3 months. So we've got to be realistic also. And sometimes it's just luck. Okay? So you've got basically that individual models must consider issues relevant to others. Interpersonal, okay, environmental and cultural factors. You've got to look at the whole picture. A little bit about community-based models. And this is basically, we talked about what individuals can do. Now we're going to talk about in groups. What do people do in groups? Well, we know that health promotion has a focus on individuals, but we also know that neighborhoods, organizations, families, and our friends have an impact on what we do and don't do. Okay? Just where we live, where we grew up, our culture, our community, our society community level, all of that has an impact as to what we do and don't do. Social ecology tells us that health promotion activities are agreed on and developed by community members. The ecological framework tells us that people will choose to take health actions on the basis of need, but not all people have the same opportunity for choosing. Okay? So if you're in a group, some might determine this is what we need to do. Not everybody gets a choice. Okay? Multi-levels of interventions to increase community competence. So again, motivational issues. You've got to have self-efficacy, believe you can do it. You've got to have self-esteem, positive attitude, perception of health and well-being. An individual's social class affects the physical activity patterns. We also then have to look at these barriers of physical activity that may include time, effort, obstacles, just the knowledge, skills, and cost. I know that there's a project going on in several of the border towns where there is a high incidence of diabetes, and they're trying to get women to go out and start walking, like forming walking groups. Well, I think it's a great idea, and we see how many people out here walking on the track. But culturally, that's a little, they're telling people, we'll do it after work. Well, no, women are at home preparing their dinner, taking care of their kids and their homework. And in these communities that they try to go in and provide this intervention, women are like, I'm not going to go out in shorts and walk around my neighborhood. It's just not something that's culturally appropriate. So they're having to come up with other plans, and what they've come up with in one community is they gathered them and said, okay, how can we get you to walk around? So they have an activity center at one of the churches, and they go there and they're walking inside. Because the other factor is that the valley is very hot. So again, now they're willing to do this. They're in there together, they're socializing, they're not outside walking in shorts, it's not hot. So those are the type of things that I'm talking about, that in a community level you need to look at all of that to know how are we going to make an impact, instead of just saying we're going to go in and say this is what we got to do. Okay, few directions for research and intervention. What do we need to do in our future? What do we need to determine? We need to know that there's the importance of thorough and appropriate assessments, which is what I was talking about. You need to go into a community and determine, what does the community need? What is the community willing to do? Okay. We need to talk about the importance of lifestyle changes in achieving healthy outcomes. Now, ultimately, what we want is a healthier outcome, a healthier person. Again, talk about, make sure that these community programs are culturally sensitive so that your health promotion effort will be a productive one. And the importance of the theory-based interventions. If we know we've done something, did it work? And learn from that. Okay. So I think that, one thing that we can kind of sum this up with is that it's important that we honor and respect and encourage, as long as possible, the independence of our elderly and the independence of all of us. Summing it up with the words autonomy, honor, and respect. Because I think ultimately, as we age and as we get older, that is what we want. Right? So I would think that many of us think that this is how we're going to retire. Is this retirement? Is this what you're thinking, maybe a retirement? Well, I would like to challenge everyone to think of retirement as this. Just enjoy retirement, be active, get involved, and look and think about your wheel of 7 things you want to get involved in for wellness. And it has been said that the mark of a great community is how well it cares for its most vulnerable citizens. Some of us provide care for our own parents and loved ones. Others are coming to grips with our own inevitable aging process. Any questions? Thoughts? Feelings? Questions? Reflections? My favorite word is reflections. That's what it is. Nobody? Okay, I've got just a few minutes and I'll share. Yes?
I actually have a question for you before you do that. And it may be that our students haven't gotten out into community nursing homes yet, which is something we need to talk about soon. But as opposed to just the ECTC, which is a captured environment with the VA, and you can't really go by that in the real world. But one of the things that we see is nursing assistants and sometimes even directors of nursing and LVNs whose mouths are just as bad as the patients that you've been showing up there. And you sort of have to get them to change their attitude about oral health before, in their own mouths, before they're even going to address what's going on in their patients. And perhaps you have some suggestions that you could make for how hygiene students in a special project might want to do something like that.
Absolutely. I would say that half of the students will be doing a community project next year, or it actually starts in the fall and it continues through the spring. And they do get to select their own site to go visit. The other of you are either involved in taking students or have done this while you went through your programs. But we have students that actually go to nursing homes. And this last year there was 2 different sites that they went to. And both times they actually met with nursing and nurses' aides. Because with that same thought in mind, if you can train them and give them the skills, they will then value the importance. Remember I said, if you think it's valuable, if you think it's important, you will do that. And so they went several times. They've done I think I want to say it's been every year for like the last 15 years. There's been at least one nursing home visited. And we've got, we do a research board and we determine. And what happens is you actually do a pre-test and try to evaluate what do the participants know. And then you go at a minimum of 3 times to educate and to do different sessions with them. And then you do a post-it. You give them the same test once again to see what have they learned from your visit. Okay? And there's been remarkable difference. What's been very challenging is to get the higher step up, which is the administrators in the nursing homes, to value the time that the nurses' aides are with our students or with the hygienist, because they are needing to be doing their work. And so that has been the most challenging, I think, is to actually have administrators give them the time to do that. One facility said we could go in and do it, but the participants had to stay after work to do it. So how successful do you think that was? It wasn't. You know, I think we wound up with 3 people wanting to do it. And you do see that. You see that because, again, we talked earlier, it's a group of professionals that are paid minimum wage. Do any of you have input on that? Somebody have any?
Just a different angle to go at it. I had the opportunity to go talk to LVNs and Hygiene and elderly and oral health.
Right.
And I wasn't really sure how receptive they were going to be. And they were very receptive, and I just encourage other hygienists to get out in the community and give a little bit of your time to do it. I mean, it's just a short, an hour presentation, and they were a great audience. It was, I really felt like giving them that before they got out, they would at least have the knowledge before they got into actually working out there.
So these were LVN students?
Yes.
Oh, that's wonderful. The other thing too is, how many times everyone looks in the mouth and they make you go, when you go in, the nurse and the doctor, but they look past the mouth and they're just looking from the throat on. So it's getting people to look at the mouth a little bit.
Another suggestion, and that's really good, what she mentioned, but another one is going to the nursing aid schools. There's smaller classes, there's usually only 10 to 12 students in a class, so, and they're very short. They don't have a lot of time, but they love having speakers. That would be a good start. We could spend more time instead of, like you said, the administrator don't want to, they're paying for your time.
Sure.
Really, because you're taking them away. So if you're getting them at the school, you could stay on. They'd love it.
How many nursing aides, maybe Michelle, how many nursing aid schools are there?
There's quite a few. But
And even St. Philip's has started a program here, and not SAC has started one.
But
Sure.
I think they closed or.
But that would be something.
They just started a new gerontology program as well, and I think St. Philip's wanted to do one, and there are several available online and nationally.
Oh, there's a lot of small ones too.
Yeah.
The Lady of the Lake, they have a small one that the nuns have, but only a 10-day course.
Right.
And they're trying to teach us so much that it's nice having visitors.
Right.
And to get them, it's so hard to get them to understand when they're teaching so many things tonight, but to have you come out.
That's a good idea. So something to keep in mind instead of going to the nursing home, maybe going to the school. for example. Any other questions?
They're online under the health department. They have a look at schools.
Any other questions or thoughts? I'm going to share just a little bit that I prepared. I think most of you, or some of you, know that I've been the caregiver of my parents for a very long time. And just like we've had some speakers come in and say that, you know, how people come in and they take 12 medications and they have the list long of ailments. Well, that's my mom. And my dad was actually not as ill, but he passed away 6 months ago. And what I did they were married 63 years. And what I did for their 60th wedding anniversary was put together a photo exhibit. My hobby is photography. And I called it Los Pueblos de Mis Padres, which is photographs of the U.S.-Mexico border where I was born and where my parents lived all their life, which is Eagle Pass and Piedras Negras. And actually had it displayed at a gallery and had them come in and just be surprised and surprised them with it. And that was their 60th wedding anniversary gift that I gave them. So I just wanted to share a few of those because one is I love to share my photography, but second is that I think it's important that we think of how we can honor our elderly. How can you honor your grandparents? You know, and this is my form of reflection. I use my photography for reflection a lot too. So just to share a few of them. This one I entitled Guadalupe. This lady has been in the market square in Piedras Negras forever and ever and ever, and I think she looked like that when I was little. This one's called Nopales, Breakfast of Champions. Has anyone here eaten nopalitos? You people? It's like, yeah, it's the combination between okra and green beans, and then you mix it with eggs.
I know they smell good.
Yeah, and she's the third generation that's at the same stand or at the same little site selling nopales, and she actually cleans them and then bags them. I call this one El Trono, the throne, and I really like this one because I spent some time talking with this man, and he had a customer and was shining his shoes, and he and I were talking, and then I had already asked him about taking his picture. And after I wanted to develop a little rapport with him, I said, so can I take your picture? And he just told the man, he told the man to get down because he wanted to sit in his chair. And that's why I called it the throne, because, and if you really look at his face, he's got a lot of dignity in his face, you know, what he's doing, and so that's why I thought it would be an appropriate name. Gotta have piñatas and colorful, as well as the fruit.
Nice color.
La dulce vida, the sweet life. Gotta have Mexican candy, right? In a picture. I call this the market square sleeps, el mercado duerme, because we're so used to seeing a market square with all the bright colors and all the noise and all the people. And I thought this was real appropriate. It was dark, it was just one person far away, and the market square was sleeping. This one's called El Primer Beso. It's actually a collection of 28 photos. These are just a few of them. But this was called the first kiss because that's where my parents gave each other their first kiss. And so when we actually had my parents come in, we had right here. We had my mom come up to that picture, and she just turned all red. So even after 60 years of being married, she was still blushing. I call this one La Siesta. This one is probably one of the ones that took me the longest because I took the picture before I had asked him if I could take his picture, and he took a very long nap. This one I call Blessed Among the Curious, Bendita entre las Curiosidades. Just deep in thought. When I show this one of Las Cazuelitas, I talk about the importance of food. Oh, I don't know what I did. That was probably the last one. The importance of food in our culture, and not just our culture, but the interaction that goes on when we're having meals together as a family, and the importance of that. This one I thought was really appropriate, especially since I found it in Mexico. It says, it's time for a change in history. Una mujer para presidente, a woman for president. It can happen. This was the soul of the corner, el alma de la esquina, and I think he's the soul of that corner because he's sold fruit at the same corner for like, 23 years when I took these pictures, so it's probably like 26 years now. 3 flags, no border. Tres banderas sin fronteras. And somebody actually told me that those flags were flying in the wrong direction, right? Because how don't we typically see the flags going the other way? And I said, oh, that's just because that's the way the wind blows in Eagle Pass. And then this is my parents' 50th wedding anniversary picture. Okay, any questions or thoughts?
Just one thing, if you do get a chance to go to the schools, and they're all confused at the nursing home schools, please bring your dentures, bring as many dentures as you can. That's one of the hardest things is they'll have 1 or 2 sets of dentures and 10 to 20 students trying to teach them all how to brush them at the same time. That's difficult. So bring all the dentures you can.
Okay. All right. Well, thank you. Thank you.